Dr. Madu, what procedures are you capable of doing in the clinic, and are there procedures that you are not able to do that you must refer to a different hospital or doctor, depending on the patient's situation?
Right. That's what we do. We set up the facility in a way that we can begin with a complete consultative service to the non-invasive diagnostics, to invasive diagnostic work, and to the invasive interventions. Now, just to make it clear what I say to people, because this question is a very important one. It hinges on one of the things that keep people from moving forward. Like, one of the challenges we had coming is some people will ask questions, but are you going to be able to do this? I say, no, we can't do that yet. He said, well, why don't we wait until we can do everything? Even within the United States, you will be surprised to learn that even the best hospitals in the United States do not do everything. There is always one thing that you will not have the ability to do. Now, for us, that fortunately, 95% of the things that are needed to take care of a cardiovascular patient, we can do. Now, there are a few things we're still not able to do, and those things we will have to find a way to get the patients to where they can be done. There are some things that probably in the foreseeable future we may still not be able to do because of logistical problems. Let's talk about heart transplant, all right? We cannot do heart transplant because to do heart transplant, you have to have an organ registry. You have to have a way of transporting, harvesting the organs, moving them. And when we're talking about cardiac transplant, it's one organ. An individual has to be dead, and that organ has to be harvested within a short period of time and then transported by helicopter or air ambulance within a short period of time. It is something now CARICOM as a unit can set up an organ procurement and delivery service. That is the only way cardiac transplant can be done in the region. Now, we do everything else. There are other procedures like radiofrequency ablation for hypertension that started out recently, but now it is kind of a little bit shaky. We are not doing that. But most of the things that are needed, we're able to do, fortunately.
With your experience and qualifications, you could have set up clinic anywhere in the world, the United States for a very high salary job at one of the major hospitals. Why focus on the Caribbean, and why especially Jamaica?
Well, we did, so we started, the career, my career actually was built in the United States. And that's why I'm still in the United States. That's where I do, most of my thinking, from. Now, we came to Jamaica, for me, it is a social movement. Setting up the Heart Institute of the Caribbean is anchored in our tourism. We believe that we have done this thing. We're doing it in the United States. And we have been recognized for knowing what we're doing. Why is it that people continue to suffer in our own communities? Because these things are not being done. And inside a place, in the problem, you may not recognize what the opportunities to make a difference are. Sometimes you have to put on a different pair of glasses before you can see. So for those of us that have put on a different pair of glasses, and we're doing these incredible, fantastic things in the United States of America, and we see how it can be done, we saw it as an opportunity to come and make a contribution, to make a difference at home. I call Caribbean home. Caribbean, Africa, they're all home for me.
I want to take a very, very quick break because we lost so much time. But I would like to leave you with this question before the break. Are the governments in the Caribbean aware of HIC and your vision to bring affordable healthcare to the poor communities? And if so, what kinds of collaboration do you have so far? So I'll leave that with you, and I'll take a quick break.
Okay.
We are back with Dr. Ernest Madu. Dr. Madu, the question I asked before was: are the governments in the Caribbean aware of HIC and your vision to bring affordable health care to poor communities? And if so, are there any kind of collaboration so far?
I wish the response would have been yes, we have governments across the Caribbean beating down our doorsteps to support what we're doing. On individual levels, we have had officials within governments within the region have expressed their desire to support what we're doing. We will, of course, like to see the governments within the region embrace what we're doing in a more constructive way. We will love to work with them to improve access to quality of care within the different communities within the Caribbean. We're doing this on our own for the most part. And I'll tell you some of the collaborations that we have created, to forge this, to forge relationships and force this, progress. We've created a mobile cardiac service that go out to public hospitals, to perform procedures that do not exist in these public hospitals. We finance it entirely out of our proceeds. We would like to see an expanded approach to this mobile cardiovascular, program. The way that can happen is when the governments come in and support what we're doing. It gets a little bit more complicated when your cost of doing business is very high, because most people think we'll get duty concessions for bringing in equipment and medications and so on. We don't. We pay very high duty, which is surprising to many people, because in some areas of industrial activity, like the hotel industry, I understand that they have almost 100% duty waivers. It doesn't happen in medicine. We pay a lot. That's why, again, we have to be very creative in managing our resources. We're working with the University of West Indies Hospital cardiac surgery program. We don't do cardiac surgery in the facility, but we have a streamlined process with the cardiac surgery department at the University of West Indies Hospital. We have some excellent young, physicians working at that cardiac surgery program that work closely with us. We also work with University of Pennsylvania, where some cases that cannot be done locally or where the individual wishes to go abroad, we facilitate them going to Dr. Zama at the University of Pennsylvania. And for the local program, we're working with Dr. Joseph Bligen. Dr. Bligen is a young man who is working very well with us, and we have a consultative service in cardiac surgery at the Heart Institute, where he comes and evaluates patients. We have CAT conference with our interventional cardiologists. We're hoping to expand the cardiovascular surgery program with the University of West Indies Hospital, so that these patients can have a more seamless approach to getting their cardiac surgery needs met.
In the chat room, Kim asks, what is atrial fibrillation and who is most still at risk?
Yeah, atrial fibrillation, it's okay. The way to understand it is that the way the heart works is it begins with electrical activity and ends up with a mechanical activity, right? Take your car, you get into your car, you turn the ignition on, the lights come on, that's the electrical activity. And then you crank it up, the engine comes on, and you let go, the car moves. The heart works, the human body works the same way. So the electrical activity starts from the upper chamber of the heart and then goes down to the lower chamber, and then the heart pumps, the blood goes, and so on. So that electrical activity coming from the upper chamber of the heart is a very organized, synchronized activity. It comes from a central station that sends the impulses down and then activates the rest of the chamber. Sometimes different areas begin to act autonomously. They go on a rampage and start generating their own electrical activity. In that sense, now the organized electrical activity is lost, and we have a disorganized activity. That is what atrial fibrillation is. Now, who is at risk? Hypertension, high blood pressure is probably the number one most common cardiovascular antecedent cause of atrial fibrillation. So most people with uncontrolled hypertension will be at risk. People that have had ongoing cardiovascular problems could be at risk. People with pulmonary disease, chronic obstructive pulmonary disease, will be at risk of developing atrial fibrillation. And as we get older, that risk increases. But if we have the conditions that I have just described, then our risk for developing atrial fibrillation is increased. Now, the danger of atrial fibrillation is that as long as this rhythm, this electrical activity is disorganized, then there is a likelihood that blood clots could form, and those blood clots form could dislodge at any point, and then a stroke can occur. That is why we want to correct it.
And Kim asks again, what can an individual do in the daily life to prevent the risk of heart disease?
The basic things that we recommend is first begin by recognizing the risk factors for cardiovascular disease. Some of those risk factors can be modified, some cannot be modified. Now, the modifiable risk factors are what we focus on changing. Now, those will include high blood pressure that you can control, diabetes, you can control, exercise. The more sedentary you are, the more your risks. So we recommend exercise. Tobacco use is a risk factor. So if you're smoking, you need to stop. Incidentally, again, this is why we have to be very aggressive. Most people do not recognize that the greatest rise in tobacco use, again, is in developing countries of the world. In Africa, sub-Saharan Africa, for example, is growing at 4.3% per year, while in the rest of the world, smoking is going extinct. Now, high cholesterol is another risk problem that you need to work on. So diet is very essential. Nutrition, dietary discretion, is something that we recommend. Watch your portion size, eat the right things. The fruits and vegetables are good for you, and watch your weight. It's the more your body mass index increases, the more your risk for developing insulin resistance and diabetes, and those will put you at risk as well.
Romeo said, as Jamaicans, we eat a lot of rice. How is that related to heart disease?
Well, rice is carbohydrate, and it can make you put on a lot of weight. So if you eat a lot of rice and you don't exercise, yes, we do eat a lot of rice in Jamaica. If you eat a lot of rice and you don't exercise, you're likely going to gain weight, and your waist circumference is going to expand. That increases your risk. And like I said, if you gain weight and you increase your risk of insulin resistance and diabetes, that puts you at risk for heart disease as well.
And Patrick said, it seems counterintuitive that the developing countries have a higher incidence of cardiovascular issues. What are the reasons for this?
Well, okay, yeah, it is indeed counterintuitive. It may not be that they have a higher prevalence, so to say. What it is that the outcomes are more devastating. The disease burden is higher because you go into a lot of things. Health literacy is one. For those of us who live in the United States, we know that calorie counting is routine for most people. People go into a grocery shop and they spend all the time looking to see what the content is. We're not that health literate in developing countries yet. Exercise is a common thing. Look at the number of exercise facilities all over the United States. People are buying up gym memberships. They're very conscious of their exercise level. That's why the wearables that have come in, the Fitbit and all of these things, are getting a lot of rave reviews. We are not there yet in developing countries. Disease surveillance in terms of looking at risk factors and catching them and treating them. We're not doing that. Hypertension, for example. In Africa, for example, most people do not know that only 20% of people that have hypertension have been told that they have hypertension. And of all the people that have hypertension, less than 10% are treated to goal. right, are treated at all to any sufficient level of control. And if you're looking at people who are treated to target, in many communities in Africa, it's less than 1%. And so if you have less than 1% of hypertensives in certain communities treated to target, then you can see that the risk burden is going to be very high. The risk of cardiovascular, the disease burden for cardiovascular disease and stroke in sub-Saharan Africa is 5 times the disease burden in Western countries. And then if you can treat hypertension to goal in Africa, for example, you can save 250,000 lives a year. So we have a lot of fundamental issues. And now this is in the area of individual control. Then we talk about institutional issues where the infrastructure is weak. We do not have facilities where people can actually go and get well taken care of. We do not have facilities for intervention. And that is why the work we're doing is extremely important. And because these things have not existed for many years, people do not see the need for what we're doing. But what we try to highlight to them is that the epidemic of cardiovascular disease is going to be a lot more devastating than anything else they have encountered, because the infrastructure is simply not there, and people are affected at their most productive years of life. And when they succumb to cardiovascular disease, it devastates families and it devastates national economies.
Raphael said, I understand that the lowest national incidence of hypertension is found in Nigeria, and the highest is Germany. This should imply lower incidence of heart disease. Is this correct?
Well, that's actually not correct. Because when you look at the statistics in Nigeria now, hypertension is rising. Because when we talk about westernization of indigenous cultures, people are no longer living in rural areas and going to the farm and exercising as it were all day long. People are moving to the big cities. They're driving through drive-thrus and going to, fast food restaurants. The mark of affluence is now to sit in your air-conditioned car and order as much burgers as you can. Now, that is leading to a rise. We have 2 cardiac centers and we have built in Nigeria, and we're seeing a dramatic increase in cardiovascular diseases in the country.
Why should the medical community pay attention or adopt the concept of early intervention?
Well, what I have said is that prevention is the most cost-effective strategy, especially in societies where the resources are minimal or non-existent. Because if you have a heart attack or stroke, the cost of treatment is very high, the cost of rehabilitation is very high, the cost of ongoing treatment is very high, but the cost of prevention is very low. And there are community initiatives that can help in forcing the issue of prevention. One of the easiest things that people can do is walk. There is no cost associated with going to the local parks and then walking or jogging or running, especially if you're able to do so. But we also recommend to individuals who have been inactive for so long that before they embark on any aggressive exercise routine, to check with their doctors to make sure it is safe for them to do so.
Dr. Madu, I don't want to take advantage of your time and abuse this new relationship, but may we have 10 more minutes of your time, seeing that we started so late?
No problem.
Okay, thank you, sir.